welcome Dr. Alex Bonnecaze, a very good friend of mine, colleague, and the co-author of our second article together. It's an incredible article on harm reduction, and the focus of this article is actually for physicians to teach them. So, Dr. Bonnecaze, thank you so much for coming on today. Please get right into this article and tell us what's going on here, because you're the main creator of this work.
I appreciate you having me on again, Dr. O'Connor. I had a lot of fun last time and hoping to talk about our second article and kind of spread the news to everyone. So this is an article I started writing about a year, 2 years ago, just kind of looking through the literature and seeing how other medical experts were starting to come out with approaches for helping men get off steroids, or just kind of what clinicians should do when someone maybe is thinking about quitting steroids. But I couldn't find any literature that reviewed what do you do in terms of managing health complications of guys using steroids that aren't ready to quit, or they're just not at that stage where they're ready to kind of go down a cessation or kind of getting off of steroids. So I felt like there was a gap, and there wasn't a good source of education for the average clinician or family doc, internal med doc, who maybe is seeing these guys in his office and not sure his or her office and what to do. So this article, it's entitled Harm Reduction in Male Patients Actively Using Anabolic Androgenic Steroids and Performance Enhancing Drugs, a Review. We were very fortunate to get accepted into a major internal medicine journal, the Journal of General Internal Medicine. It's one of the major internal medicine journals. And why I wanted to write this, as I was saying, is just as a guide. So perhaps a patient is coming into the office, the clinician is not sure what to do. Like, I have this guy on steroids and he's asking for help. I envisioned this as something they could print out, kind of look at and go, okay, here's where we're at. This guy's using X, Y, and Z. I can check this lab. These are the complications I have to watch for. These are the steps to maybe help them eventually consider coming off of steroids. And so that was kind of what I envisioned. And I'm just thrilled that we were able to kind of work together and get that published, so others in the medical community could kind of start using that as a stepping stone to help these men.
So let's go back in time,
Mm-hmm.
Dr. Bonnecaze. You and I met several years ago. You were a fan of the anabolic doc.
Yeah.
Went to medical school.
Yeah.
You're like me. You're an internal medicine doctor, which, for all the people in the world don't realize, internal medicine is internal organs, right? And then that's how we're trained. You classically know us back in the day as primary care doctors, because that's what I was. And then you decided, when you got out of your residency training program, internal medicine, I went into the streets to work, I think in part because I was old and you're not old. So I was older. So I said, I wanted to be cardiology, do a fellowship. You went on and you did a fellowship in endocrinology. So you're an internist and you're further subspecialized in endocrinology. Let's talk about this. So you could have been a primary care doctor.
Yeah.
You didn't. You're a specialist of internal medicine, endocrinology. Now, my point on this is that who sees steroid users? Who sees them up in this country, in all the country, the Western world, if you will,
Mm-hmm.
in the world. So, and who should see steroid users? Who now everyone needs. This is for primary care doctors, but everyone knows that endocrinology doctors are hormone doctors, right? For men and women, and diabetes and hyperparathyroid and osteoporosis, and boom, I know you know that. So people don't know that. And then urology doctors are surgeons, but clearly they're working with male parts, and there's even female, right, urogynecologists, right, that are kind of man woman. They're really kind of working on them, but they're surgeons. Now,
Right.
so what do we have in the world? We have primary care doctors who are going to see patients for everything: drug addiction, smoking, obesity, diabetes, hypertension, heart disease, congested nose, skin rashes, eye issues, depression. Should I keep going, doctor? Do you think I did this? Okay.
No, absolutely.
You did it too, but you
Yeah.
did it as a resident only.
Yeah.
Okay. And then you went to, so this man, guys, in the world, this is a real endocrinologist that has taken the level, because we've been working together for years. He sees that doctors need to understand what steroids are. And the fact that so many millions, one of the reasons, Doc, don't you agree? One of the reasons why doctors don't get involved with this is because if they don't understand it, they don't understand the steroids. It's the first time only, very rare that a patient comes in and is asking and looks great, versus like an AIDS patient that's using it, and we could feel sorry for that patient, but the doctor doesn't have to understand and you have used heroin, but he knows that they're going to have hepatitis and HIV, and they're going to have all the and opioids. So doctors know this, but they don't have to use them. So these doctors don't know steroids, they don't use them, but to understand the use, what's anadrol, what's decadrabline, NPP. These doctors, they don't even understand how testosterone is used. You know that.
Well, and I think you hit a great point, and we talked about this a little bit last time, but say I'm a primary care doc who has no knowledge on this topic, and I have a man come in that, he's a bodybuilder, maybe he's done some shows, ran some cycles, and he's had a complex regimen. He's had a guru or two kind of guide him, and he's had the whole pharmacology, bro science. He's pretty knowledgeable guy, right? And if the primary care doctor is like, Tren, what's that? Or Anavar, and it's going to create this, they're already kind of walking into the primary care doctor's office, not maybe that trustworthy or skeptical, right? Yes. Of their knowledge base. So when they have a reason to maybe kind of go on that preconceived bias and say, oh, well, these guys really don't know anything, they're going to lose trust in their doc. And so the first thing I wanted to do was educate clinicians and be like, look, this is why guys are using that. It's not that they're pro athletes. It's not even that they're necessarily bodybuilders all the time. They're guys that, due to some patients and with all the pressure of body image and just physique enhancement, there's just a lot of guys using this recreationally, most of them.
Millions. Dr. Bonnecaze, how many millions, how many men would you estimate are using steroids, people, including women, people on steroids in America?
So the data that I had from a few of the other reviews, it was this 2.9 to 4 million people in America have used anabolic steroids, basically illicit AAS use at some point in their life. So 2.9 to 4 million people in the country at some point in their life have at least tried it. And so, this is something that just because you're not maybe giving it the attention or you're not looking for it, it's quite ubiquitous. It's all over the place, right? So that's why I thought, primary care, they are going to see a lot of these guys first. We do get a ton in endocrine, but the challenge with endocrine is we have usually a couple months wait. And, I think what's challenging is they might get into an endocrinologist. They think that we're experts in anabolics and such, but a patient using anabolic steroids with anabolic steroid-induced hypogonadism or suffering from anabolic steroid withdrawal syndrome, it's quite a different kind of distinct pathology from your classic idiopathic hypogonadism or the traditional low T.
Wow.
So, I think it's a special thing that we don't get a ton of training in, and other experts have tried to kind of expand education, but I just felt the need with this to kind of dive in and say, let's spell it out for the primary care docs, the clinicians, any other specialists or endocrinologists who might encounter these patients. And what I did and what we kind of worked on together, I gave them kind of the data. And then I also just went over like some sample cases. Like, these are some guys you might experience. Like, particularly I wrote about a case saying, oh, this guy came in, I made up a case, but it was like, based on kind of a typical scenario. And, a guy in his 30s comes in, maybe he has high blood pressure, been using steroids for a while, just wanted to get his labs checked. And then the doctor, wanting to help and not really knowing what to do, he kind of says, well, I think you just got to come off this stuff. And then maybe once you do, we can chat again. And, a lot of times what we see happen, and that was classically what was done, these patients, they feel kind of rejected. They feel kind of pushed away. They go back to their natural kind of environment and circles, whether it's your other friends using AAS, the gurus, or maybe they try and quit and they have really bad anabolic steroid withdrawal syndrome, where they're having the depression, the anxiety, and then that pushes them to further cessation. So, I think this view of telling these guys, just get out of my office until you quit, that's no longer really appropriate care. We have to be compassionate. And, like you said previously, there is no room or reason to judge. Whether it's IV drug use, smoking, anabolic steroid use. And I've even heard clinicians say, hey, well, if this guy's using steroids, I'm not going to check his labs because if it looks okay, I'm just going to encourage the guy to keep using it. And I think that's crazy. Yeah.
But let me put a point in here, because so for our colleague, again, this is for our colleagues, guys,
Yeah.
right? This is for our colleagues that we're showing them the way. Now we have data. Our
Hmm.
colleagues, we're evidence-based doctors. We're all internists, right? This is
Hmm.
mainly for internal medicine, GPs, family medicine, and for any doctor or nurse practitioner that we see patients
Absolutely.
in that setting. That's not a specialist and certainly doesn't what the data is clear. A man comes in on steroids, and again, women are using steroids too. My lord, of course they are. But
Sure.
the classic anabolic steroid-induced hypogonadal, they come in on steroids. They're at risk for getting hurt, right? For DVTs, myocardial infarction, right? Polycythemia, androgen-induced erythrocytosis, psychiatric. Please, I'm begging doctors to understand this. Look at the data.
Yeah.
We've paved the way, and there are other experts in the world that have paved the way prior to us. No names mentioned. We just don't need to say who they are. There's a few of them out there. This is a revolution, and it's a needed revolution. There is data. We're not giving any blessing on steroids. You don't
No.
have to. But if a man walks in and using heroin into the ER and has pneumonia, and you understand that you need to interact and to intercede and protect, we have a whole, in all the ERs that I worked in the Northeast, in New York and in Connecticut, we had protocols. Don't we, doctor?
No, and I think that's exactly what I was getting at. I mean,
This is protocols now. You're going to interact and hold them and hug them. You don't give a blessing. You can be stern,
mhm,
but they're right in front of you, and there's complications acutely, and then
yeah.
they're going to come off. The FDA has placed, doctors, listen to this and check it out, doctors.
Well, let me give you an
FDA,
example, and you know
the
this, but I
FDA,
mean,
the FDA has given a warning for withdrawal and
right.
addiction. I'm done.
No, no, I agree. And I think that, as an example, like 30, 40 years ago, you would never imagine that a health center would give out, sterile needles to an IV drug user, right? They say you're encouraging these people to use, but I trained up in Seattle for medical school, and that obviously is a big center where there is a lot of issues with IV drug use, and we're trying to take compassionate care of patients. And I know in that region and other cities with that issue, they had needle exchange programs, right? Or they did things like Narcan prophylactically for harm reduction. No one's giving a blessing, but we're saying that there are these activities going on. We want to help protect these patients until they're able to quit doing the unsafe activity. Let's take smoking cessation. If a patient is using cigarettes in a specific quantity, they have recommendations to do a low dose CT to screen for lung cancer. Now, to that same argument, if they don't have a lung nodule and their CT is clean, it's not that we're saying, oh, well, everything's fine. We still continue to help and assist with support resources for cessation, but we want to catch something before it becomes catastrophic, right? Same thing applies with issues like accelerated atherosclerosis and early atherosclerotic cardiovascular disease in these men. That's why things like the coronary calcium, screening the lipids, seeing if they have additional family risk factors for dyslipidemia that'll make them prone to early stroke and heart attack. And I think that's really kind of what it's just because a topic gets more controversy, it doesn't mean that it's our job as a clinician to judge an activity, whether it's the IV drug use, the smoking cessation, whatever lifestyle choice that someone chooses to make. No one's giving a blessing on any of those things, but we're not turning those patients away. We're still wanting to do good medical supportive care. And like we were saying, the biggest thing in this article, it's really big picture cardiovascular, right? I mean, we talk about some other stuff. We talk about things even like watching bone health on aromatase inhibitors and some other kind of things with the fat burning compounds that, can be really lethal. But big picture with the anabolics and the androgens, we talk a lot about making sure that these people aren't at risk for early heart attacks and strokes. And if they are, maybe that's a motivation to stop, right? How many men have you seen that they have a really high coronary calcium or their echo has some LVH? Have you seen any men say, oh my gosh, this is the turning point for me? Have you noticed that?
This is it. This again, we're internal medicine doctors. We feel comfortable with hypertension, diabetes, dyslipidemia, comfortable with talking to people about cigarette smoking cessation, alcohol, even drugs now, like you said,
Yeah.
illicit drugs. I want doctors, we want doctors to feel comfortable.
Yeah.
We want them to be comfortable, to feel that we have your back. We forged the path. You're not going to lose your license. It's unethical. You're not, but you don't have that man in front of you, again, or woman, is not looking for you to write a script.
No, and they don't. That's not that. That's an excellent point, because there's not, like we talked about, the access to this is so easy for any of these patients. They're getting friends, internet, whatever, and I make I'm pretty, I'm fairly conservative, in terms of my practice, but I mean, I try and be very, I try and define, are we doing pure harm reduction, or are we doing, trying to do a supervised kind of cessation approach? So I just want to make sure everyone's on the same page, and then we'll do things like help them get, in touch with behavioral therapists and the whole support resources. And so I go over that as well, as, in this paper, where it has to be that team approach, a good support system. And then, but at the same time, I mean, have you seen men where they look at that coronary calcium or echo and they really use that as a turning point, and that motivates them to stop?
When you do a health history in H&P, the way you and I do H&Ps, and they look at their family history, that can be concerning. Even without that, the calcium score, you see men in their 30s or 40s, and you see a calcium score, and there's no data to support that specific steroid regimen caused it. I have executive men, I have regular men that are 35, 40 with bad family history, cholesterol, a little bit of sugar, and then they have a calcium score of 40 or 100 or higher. So
Right.
that's just the nature of our reality of atherosclerosis. When you show it to them, and then you show them their HDL, the protective cholesterol, is low, and their LDL is high, and they're hypertensive because they're on steroids, you show them the data.
Exactly.
People are not dumb. They're starving. They come to you, doctor, because they have respect, and they come to you. They're concerned. They're nervous. They're nervous. They want help.
Mm-hmm.
So we understand that doctors are nervous and liability, but now you're safe. We've provided protection for you, doctors. This is an evidence-based journal, right? And it's interesting. We don't need to go into how it wasn't easy getting in these journals, and I appreciate that. That's called peer review.
It shouldn't be easy, right? I mean, because you shouldn't be able to just make up anything and get it published and in a good journal, And so, I mean, that's why you have peer review, and why you have people from multiple backgrounds reading articles. And I agree. I mean, these guys are not coming to the doctor to get their steroids or something. It's largely fertility issues, or they were at least in the pre-contemplative phase of maybe thinking about stopping, or they're maybe worried about, oh man, my dad had a heart attack, or my relative had this cholesterol issue. What's going on? And to your point, I have seen the approach where some clinicians have maybe said, you use steroids and you got this complication. And to me, it's not about that, right? Like, to me, if someone has a high coronary calcium, I've seen people that are not using steroids, they're young and they have very, very early cardiovascular disease from genetics. But regardless of how we got there, whether you want to blame the steroids or genetics, when you're in that situation and you're using supraphysiologic androgens, we know that is an accelerated risk factor. It doesn't matter about the blame game and what caused what. It's more about, okay, if your coronary calcium score is elevated, or you have, a really bad hyperlipidemia, and you're using these compounds, we know the data that is a dramatically increased risk multiplier. It's when we're not talking about TRT, we're talking about supraphysiologic, really high doses, where there is not a lot of controversy that high dose androgens is bad for cardiovascular disease development. So
a colleague of mine and yours, but I've worked with him directly with patients, Dr. Aaron Bagish, doctor at Harvard. And again, I'll throw the big name out there. People trust Harvard. I mean, this is a center of excellence. There are many centers of excellence, and I don't care about that. And if you're a doctor in the community in Arizona, you're a doctor in the community in Australia, you're interfacing on the front lines with these men, and you can look at the data. And Dr. Bagish is one of our colleagues. He's outstanding. He's very ethical. He's a cardiologist, and the LVH in the early coronary disease is true. It accelerates it. So, and these men on my channel, they're here for this information. And so I think we're going to wrap up on that. I feel that you came into my life with the grace of God, doctor. because I started off early and it was risky because here I am an internist and I call myself the anabolic doc. And it took some chutzpah to do, but I'm so glad it's been a long time now and I'm safe and always ethical. And as you and I have met personally years ago and we talk behind the scenes, we really just want to be leaders and healers. And that is not, that's a personal thing. And we want doctors to now follow us with this. So, but you know what? Like my wife said, who's a great nurse, write a paper.
Yeah.
I was so busy, and then you came in my life, and now we have 2 papers.
Yeah.
So you are awesome, and you're an incredible man, and of course, physician. And I'm looking forward to more research, and we're going to tease the world with what's coming next. We have so many ideas, guys. So, but let's get some comments on this, guys and
Absolutely.
women, wives, and mothers. What do you think about this? Is there? It's a kind of a no-brainer, and there's a lot of love on my channel here. Is there a reason that we shouldn't be doing this? Is there a reason where we shouldn't? Are we giving? Let's be honest, Dr. Bonnecaze. Let's because we're biased, right? Because we feel that we're very entrenched in this and we love to protect people. And we've protected people as internists when in residency training programs in the inner city with heroin use and AIDS and HIV and depression and alcoholism and cigarette smoking. We did that, and we don't. And again, 30, 40 years ago, imagine we're going to give methadone and Suboxone and to people. So now this is the next front. This is the next huge. And doctors, is it an epidemic? The numbers are much bigger than 4 million. But I don't have any data to prove it. So 4 million is the number.
Well, they've been saying, I mean, gosh, it was Journal of Clinical Endocrinology and Metabolism, either 2019 or 2020. They talked about the kind of the hidden epidemic of anabolic steroid use and body image disorders in men. And, I mean, that's a paper we quoted in there, cited in there. And, these are major, very, evidence-based societies recognizing that this is, an epidemic, and they are working on kind of things to improve it. But that's why I think, you have a different background, having years and years of clinical experience and everything, and you've seen this kind of in the trenches. I mean, that's why I think working together, getting out papers like this and getting out the awareness.
There has to be trust. In the end, patients come to us because there's trust. We have an MD right next to on the lab coat. We have the MD there.
Sure.
They assume that we're smart and that we're licensed and that we're good enough. And then the real clincher is going to be, hey, that doc is great. It's a nice guy. Isn't that amazing that that's the clincher? That's the Google 5-star because you're a nice guy. You are professional.
Makes a difference.
Responsive, right? And I'm a business doctor. I've been in the world of my own practice for almost 20 years now. So you got to satisfy people. It doesn't mean you have to break and compromise your license. Doctor, that's it. I'm going to say goodbye. This is outstanding, guys. Got to get the comments. I want to hear really from physicians, nurse practitioners, family doctors, urologists, anyone, mothers and fathers, anyone. Is there something bad? Is there something wrong that we should not look into this further and study this?
Yeah, and I think I'll on my parting thought, I mean, anyone that before, if they're able to look at the article, they'll see that we're pretty defined in what we say, and a lot of it is preventing the cardiovascular complications. And like you said, there's nothing unethical about managing a guy's hypertension or treating his high cholesterol or preventing cardiovascular disease, treating LVH, liver dysfunction, things like that, and so the article is not saying, provide them with accessory compounds to support side effects from their cycle. That is not at all what we're saying. We're talking about legitimate harm reduction, primarily of cardiovascular disease. So I encourage any clinician to kind of take a nice dive into that. We made a nice table, and we'll be able to kind of, I define that in the discussion too. So excellent point. I can't wait to see some of the comments from people.
Dr. Bonnecaze, thank you so much. And we'll be back. We'll see you again.
Thank you so much.